We are now recording, so thank you, Alfred. Welcoming everyone again to this GIN North America webinar stream featuring research in progress. So next slide, please. Because this is a different way of doing GIN North America webinars, or we're going to be focusing on research that's in progress, although this effort is mostly complete, with the series that we're unveiling, we would like to identify for you how we're going to manage this one differently compared to prior events. In our prior events, we've let the speakers talk, and then we would do a discussion, question and answer period after. This one's going to be different. For those of you who may be in universities or other institutions where you have research seminar, it can get pretty intensive with the delivery of the content of the research, but there are definitely opportunities for you to send questions via chat feature to the host, which in this case is Rock Creek. So during the presentation, so throughout the presentation, please feel free to send questions that would help you to understand something that the speakers have said a little bit better than you are understanding it to be. So maybe they're using a term you don't understand, or maybe they haven't defined a term that they're using in the way that you think it may be typically understood to be used. Those are just a couple of examples of the kinds of questions. If you send a question to the chat, I'm looking at them as the moderator, and it appears to be a question that might be best suited for the discussion period, I will hold it until then, because that's when we're going to do those more deeper kind of questions of, you know, why did they choose this design over that design, and things like that. So please feel free to send your question through chat during the presentation if your question is of the clarifying type. Slide, please. Okay, so without further ado, I am going to turn it over to Dr. Boyd and the research team to begin the presentation. And for our speakers, please just let us know when you are ready to advance the slide. For our audience members, we will be doing some polling. The research team has integrated some polling questions into their presentation. We will run those. So sometimes when we do those, it takes a little time for the polling aspect to load, but our speakers are prepared to help you get through it quickly. So with that, Cynthia, Dr. Boyd, and the team, I turn it over to you.
Thank you so much, Mary. We all very much appreciate the opportunity to present to all of you and GIN North America's facilitation and invitation to do this. Helen, Milo, Craig, and I are presenting on behalf of a fairly large project team that spans several institutions and has been a really wonderful partnership, including Johns Hopkins, University of Zurich, and Kaiser Permanente, both through Kaiser Permanente, Colorado, but also some of the other KP sites, and we have worked closely with their Care Management Institute as well. We've also had a wonderful team of patient and caregiver partners who will list everybody's name at the end. So if we can, in just a minute, go on to the next slide. But first off, we're going to be talking about how we inform patient-centered care better for people with multiple chronic conditions. This is a project that's funded by the Patient-Centered Outcomes Research Institute through their Methods program, and we're grateful to them for their funding and their interest in this topic. So for the first polling question, there, I believe, will be a place for folks to mark off which of these are the best one to describe you through the webinar. Mary, do you have additional instructions to tell people how to choose the answer?
No, I think once we can launch it, it'll be clear that all they have to do is hit one of those radio buttons and their answer will be logged. So I'm looking at Alfred to, I think we're ready to open the poll when you're ready.
Okay.
So we've opened the poll, and people should be seeing on their screen over in the right-hand rail, if it's appearing that way. That's how I have it on my computer, but I'm not fully open yet.
No, it's visible now. So
yeah.
Hopefully we've listed the category that best describes you. If not, please click other.
Right. So if you do not see the polling questions, go to the top of your screen and select the polling to display. Yeah, but it's not. Yeah, hit escape. Right. So I find it on my computer when I hit escape. Right. And go back to minimal screen. Yeah, return. Or return, right. So that you can see the polling question. How many responses do we have?
Okay. So those questions will stay as we move on to the next slide, correct, Mary?
Yeah, actually, I'd like you to hang tight for a minute, Cynthia. What we're seeing, in case we lose the results, we're going to close the poll, everyone. Thank you for participating. We hope that the results will show. Sometimes we have some issue where they don't all show. So if you can hang on, Cynthia.
Sure.
Okay.
There we go. I see them
right.
listed. Great. It looks like we have a lot of folks who are guideline developers, some different types of clinicians, some folks who've listed other, and that some folks were not able to answer. That's helpful for us to know who's in the audience, and I think is helpful for GIN North America to understand who's participating.
Exactly. Thanks, Cynthia.
So can we go on to the next slide, then?
Yes. Alfred's advancing now.
Great. So our PCORI project's purpose was to see if to develop and refine methods for informing patient-centered care of people with multiple chronic conditions through benefit-harm assessment. So our goal was to collaboratively define the questions of importance that we were going to be addressing, and again, this was done with stakeholders, including decision makers and guideline developers from KP Permanente national guideline panels, but was also done through an extensive process of working with people with multiple chronic conditions and caregivers or care partners who help people with multiple chronic conditions navigate their health care. The next step from that, once we had our two questions, which we'll go over in a minute, was thinking about moving on to evidence gathering and data preparation. And then we moved on to the analysis part, which also really fell under our aim 2, which is to do benefit-harm assessments and inform the KP national guideline panels about the results, and then to develop guidance for basically using and improving upon these methods, again, with the purpose of informing patient-centered care for people with multiple chronic conditions. And we've linked to the PCORI website that describes the funding and the project a little bit more. I'm going to turn things over to Milo for the next slide, which we can advance to.
Good. Thank you, Cynthia. So this is just an introductory slide that probably reflects well what guideline developers are confronted with when they need to come up with recommendations. So these are just results from a systematic review. I chose an example from an area that I'm very familiar with, from COPD. It's basically the results of a systematic review on a new drug called roflumilast. That's not so important, but what you see here are 6 forest plots and the meta-analysis for 6 different outcomes. And you know that the drug is supposed to improve lung function, to lower the risk of exacerbations, but it does come with harms like nausea, diarrhea, weight loss, headache, and there are a few more. And you clearly see that there are benefits. It does improve lung function, it does reduce the risk of exacerbations, but it clearly increases the risk of these side effects. And the big question is now, how do you make sense out of these data? How do you judge whether the benefits that you observe outweigh the harm? And let's move to the next slide, because before I give you any clues, I would like to ask you, if you see results like that, do you think this COPD drug should be approved, like assuming that you are a regulatory agency that has to approve or not approve the drug? So just please simply choose yes, no, or I don't know.
Okay, we have about 30 seconds left before we're going to close the poll. If we see that people have stopped, we'll just close the poll. Thank you. Yeah, looks good. We're going to close the poll and see what people thought about that COPD drug.
Sure, and until we see the results, I can tell you that the regulatory agencies really had great difficulties coming to a conclusion. FDA and in Europe, EMA, they really had a hard time deciding whether to approve the drug or not. And it's the same among, let's say, COPD guideline developers. It's very hard for most to make sense out of these data and say whether this drug should be recommended or not. And we see the results. So we have about a third who said no answer, and a few said yes, very few said no, and some didn't answer. But it probably reflects the uncertainty, and it also shows, and we can move to the next slide, that we need to do more than systematic reviews to come to an analysis to come to a conclusion. And this is exactly what benefit harm assessment tries to inform. Again, you see this the process from planning to the conclusion and dissemination that Cynthia already explained. What is extremely important is, as for any clinical study, is the planning stage. And just to give you an idea about which step takes most time, so it's clearly the evidence gathering and data preparation that takes most time, because one of the key challenges is to find the appropriate data to inform and select, not only find, but select the appropriate data to inform your benefit harm and assessment. We will come to that in a minute. And we also provide a link there, protectbenefitrisk.eu. That's a very useful website to get information on the methods and some applications of benefit harm assessments. So let's move to the next slide, please. So when you start with the planning, it's really quite similar to a clinical study or intervention study, like you define your population, intervention, comparator, and the outcomes. But there's a few additional things you need to decide. One is whose perspective do you take? Who is the stakeholder? Is it the guideline developer? Is it a regulatory agency? Is it clinicians? Is it maybe also patients who want to be informed what is best for them? So that's a key issue at the beginning. And the other is population versus individual focus. So those of you who are a little familiar with methods of benefit harm assessment are probably only familiar with those methods that look at the population level, that try to see whether the benefits outweigh the harms. But through our research over the last few years, we actually figured out that you can narrow it, and you can also go to the individual focus by considering different subgroups, by bringing preferences into the equation. And this is one of the, I think, major insights that you will also get from our results, that the picture can change quite a bit if you go from a population perspective to let's say, an individual, or at least a perspective of subgroups. And this is why we always consider two key factors So one is, we always ask or try to ask, does the benefit-harm balance vary across subgroups? This will inform also the decision or recommendation, whether it makes sense to make a recommendation for the entire patient population or for certain subgroups. And the other aspect is how sensitive is the benefit-harm balance to preferences. And this is what we will highlight in the presentation, how to explore that. So next slide, please. So I hand over to Cynthia again to introduce you to the two questions that we ultimately addressed.
Thank you, Milo. So the two questions we ended up addressing were both related to things that fall within, had one condition that fell within what we might consider cardiovascular health, or our Kaiser Permanente colleagues group calls this their integrated cardiovascular health portfolio. So one question was, and people with multiple chronic conditions. So one question was, what is the best target blood pressure when treating high blood pressure in order to reduce the rate of serious outcomes like stroke and heart attack while balancing possible harms from treatment? And we have a partial list of the benefits and harms here, but the idea was really to understand in whom does this balance vary, preferences affect it. The second question related to the balance of benefit harms for the treatment decision of whether to add basal insulin or a sulfonylurea oral medication to metformin. Does that differ for some groups of people with diabetes? Again, either based on their characteristics or on the basis of their preferences. And again, we have a partial list of the benefits and harms listed here. Again, trying to highlight the idea that we're interested in that balance and when the balance varies. I'll just reiterate that these two questions were chosen with work with people with multiple chronic conditions and multiple chronic conditions, as well as in determining which outcomes were of importance was also done through a process of working with people with multiple chronic conditions and their people who helped care for them. We're not going to be focusing on that piece of the research in the presentation today. That work has been published in JGIM. We'd be happy to share it with folks that were interested. For this presentation today, we're focusing on the benefit harm assessment process for both of these questions. So if we move on to the next slide. I think we have 4 total polling questions, so we're at the third one. So 48% of people over the age of 65 in the U.S. have multiple chronic conditions. Do you think the benefit-harm balance of what blood pressure target is influenced by the presence of multiple chronic conditions? And check either yes, no, or I don't know. And we'll close the poll whenever it seems like people have stopped answering. While we're waiting for that to wrap up, I'm going to be turning things back over to Milo for the next slide. And so we could go on to that slide whenever you're ready.
Yep, we've advanced the slide, but we've also closed the poll, so the results will be available soon.
Great, thank you so much. We did not ask the parallel question about diabetes. We could have asked a similar one. We didn't want to have too many polling questions. Here we go. So it looks like a little more than half of people think that the balance of benefits harms does matter in terms of multiple chronic conditions. Very few said no, a few said I don't know, and a few people, it looks like about a third of people are either not wanting to or not able to answer the polling questions. So Milo, I'll turn things back over to you. Milo, you may be on mute. Milo?
Can you hear me?
Now we can. There you go.
Okay, good. Okay, so this slide, evidence gathering preparation, is also introducing methods. So there are various methods to do this benefit-harm assessment, and but what is common to many methods is that they put together three important sources. So one is, of course, the estimates of effects for both benefits and harms, and there the randomized controlled trials are the primary source in many cases. Then outcome risks in order to, in combination with the estimates of effect, to get absolute effects. You know, in order to put treatment effects into perspective, we need an absolute measure of effect. And many of you will be familiar with like number needed to treat, number needed to harm, which when you compare these two in essence is also kind of a simple benefit-harm assessment. So these are two very important sources, of course, and the reason why we explicitly mention the outcome risks here and refer to registries and observational studies is because we think in many instances or for many questions you get more, let's say, applicable estimates of the outcome risks if you go to these sources than if you take, for example, the event rates in control groups of randomized controlled trials, which may not reflect, let's say, the real-world population because of eligibility criteria or because of willingness of people to participate in trial and so on. So in general, we try to go to data registries, national registries, observational studies, because they give us a better reflection of the outcome risks in the population of interest. So the absolute effect is important, and when you think about for a benefit effect like reducing heart attacks and a harm like feeling dizzy, you understand that it's probably sensible to weigh these outcomes because they have different importance. And this is what some of, not all of the methods, but some of the methods allow for, that you weigh the outcomes according to their importance. And we are, our view is clearly that the weights should reflect the patient perspective. And this is why we do usually surveys, preference elicitation surveys. We're going to show you an example in a minute to get the opinion of patients about that. You could also go to observational studies like and have a prognostic criterion like 5-year survival or something like that to weigh the outcomes. But again, we think the patient perspective in terms of preferences is more appropriate here. And we provide a number of references that also goes back to some previous work we did and like reviews and like applications of these methods in case you're interested in using them. We use a particular method, and we can probably go to the next slide. We won't go into too many details, but the approach we use if we do benefit-harm assessment on an aggregate level, meaning that we take data from trials, observational studies, and not individual patient data, is an approach that has been developed almost 20 years ago by the National Cancer Institute and their famous statistician Mitchell Gale, where they developed the methods to estimate the benefit-harm balance of tamoxifen for breast cancer prevention. And we like this approach because it's very transparent. It's very transparent what kind of data are put into the equation in terms of treatment effects, outcome risks, and preferences. And if somebody doesn't agree with some assumption or how the evidence was selected, you can do it differently and just rerun the analysis. So it's also a good basis for discussing the data that ultimately enter these analyses. What you see here on this slide is a typical graph of such a that comes our table, that data that comes out of this approach. What you basically do is when you combine treatment effects and outcome risks, you estimate the number of events that are expected in an intervention and in a control group and for a particular subgroup over a certain time horizon. So in this case, we are looking at 10,000 persons, and you see the age group of 65 to 74-year-olds, where, for example, we can expect in the 140 systolic blood pressure target group, like 852 deaths 852 deaths and 694 in the 120 groups. This is the treatment effect that you can that is reflected here, and you see the difference in outcomes for all benefit outcomes and for all harm outcomes. And you see further below for the harm outcomes, you see that there are more harms to be expected with the 120 target. And so the method basically sums up the difference in events between these groups, but puts a weight on the different outcomes. So it's actually relatively straightforward and relatively simple. The tricky thing or the challenging thing, and this is again what takes most time, is to find the appropriate data that inform these numbers, so the treatment effects and the outcome risks. So let's move on to the next slide. This is where this shows how you can get preferences. So as the third important piece in for benefit harm assessment, there are various forms of eliciting preferences. You may have heard about standard gamble, time trade-off, and rating scales and stuff like that. We use, in the last few years, we used a method called best-worst scaling, which is for respondents relatively simple to understand. Other methods are very hard to understand, and you get inconsistent answers because the methods are so challenging. But what you do in this case, you have a certain number of outcomes or problems. You see acute kidney injury, low blood pressure with dizziness, falls, cognitive impairment, and heart failure. And for this, you just choose the one that is least worrisome for you and the one that is most worrisome for you. And then you have a repeated number of tasks like that where the combination of outcomes or problems that you see changes, and so they have all kind of combinations, and from those combinations you can actually then calculate which outcomes are selected relative to the others most often and least often, and you can also run some more sophisticated analysis that also tell you like the importance of these outcomes relative to one another. So this is the method that we also used in the two examples, so the diabetes examples and the hypertension example. So let's move on to the next slide. All right, so we have another polling question, which is about including patient preferences in guideline and development. And it would be for us very interesting to learn, how do you approach this? Do you identify patient preferences, and if yes, how do you do that?
And just to note, for this one, you can choose more than one answer. You don't have to choose the best. You could, if we recognize people may do more than one of these things.
Okay, very good. And when we have the results, Cynthia, I turn back to you for showing the results of our two preference elicitation surveys.
Yes. So while we're giving that a minute, I'll start off by saying, so we as I mentioned earlier, we included directly talking to patients with the two conditions that were sort of anchors, hypertension and diabetes, and multiple chronic conditions, and we specifically sought out people who had significant additional multiple chronic conditions, both for determining the questions and generating the list of outcomes that are important to patients that were included in the best-worst scalings that Milo showed you on the prior slide. So those lists of those outcomes were derived with input from people with multiple chronic conditions. And I see our results here. It looks like there's some even spread across looking in the literature, including patients on the guideline development team, surveying patients directly, estimating the preferences based on clinician input. And I note that very few people say that they don't identify patient preferences, and about half people didn't answer. So next slide. So before we go into the details of what we're looking here, I'm just going to orient everyone to who we talked to. So with the help of our team, from KP Colorado, which was one of our KP sites. We assessed preferences from people with multiple chronic conditions. There were two separate surveys because we had different outcomes for the diabetes and multiple chronic condition question and the hypertension and multiple chronic condition question. And we sent surveys to about 450 people for both surveys, and for both of them, about half of the people answered. The fact that we ended up with 217 for both surveys is random. They actually are different people, different groups of people. And what we can see here is that in general, respondents were not different from non-respondents. We had some information from the electronic health record about people who didn't answer the survey. In general, people's mean age was in the low to mid 70s, and so we were happy that we got a population that had a mean age that was this high, with pretty significant numbers of people who are actually into their 80s. And I'll just draw your attention to the QAN score at the bottom for both of these. This is a measure of comorbidity that, in general, having a QAN score of about 3 means that you have about 3 major chronic conditions. And so our mean QAN score for both surveys and for respondents and not respondents was 5 to 6. So we were, again, really pleased that we'd gotten people who had significant degree of multimorbidity. Some of you who attended the Global Evidence Summit may have seen Helen's poster, or where she presented these results in more detail, and she and Craig also did a workshop about these methods. So next slide. So here we see the results of the preference elicitation survey for the diabetes outcomes. And you can see that we had a pretty significant list of outcomes that were assessed, and we'll come back to this list of outcomes when we get to the benefit harm assessments. We wanted to assess preferences for outcomes that our patients and care partners told us were important, even if there was not evidence for those outcomes in the systematic reviews and the sort of the evidence gathering process, because we felt like that was a really important piece of understanding how well the evidence we have applies to people with multiple chronic conditions, was whether or not the outcomes were assessed. So a couple of points from this slide. One is that almost everyone in best minus worst score fell within the range of -2 to 2, which suggests that that all of these outcomes are at least somewhat important, and that they should be included, because it was possible for someone for one of these outcomes to have been a -4, which would mean that everyone always said that was the worst thing, or if it was a 4, that everyone always said that was the least worst thing. And this is really a representation of the average choice frequency, and since for this survey every outcome could have been chosen up to 4 times, the scale goes from -4 to 4. Next slide. Here you see the results for hypertension. We had a slightly different number of outcomes, but again, a pretty significant list. Here, since every outcome could have been chosen up to 5 times, that's the reason the scale goes from -5 to 5. And again, the fact that the scores tend to range from -2.5 to 2.5 suggests again that all of these outcomes are at least somewhat important to people, and that, again, suggesting that they really should be part of the way we think about evidence. I'll just note one thing, which is also true on the diabetes slide, which is, because it's something we noticed and have been asked about before, is that end-stage renal disease and chronic kidney disease were rated very similarly. And because we wanted these to be patient-important outcomes, we chose symptomatic versions of each of these conditions. So people were given a description of the condition, and our patient and caregivers really helped us to get those descriptions into lay language. But as you all probably know, symptomatic chronic kidney disease actually is pretty close to is late-stage chronic kidney disease and is pretty close to the degree of symptomatology that people would have with end-stage renal disease. Next, just to note here also that we did want to assess the burden, and then for this question, this was the burden of an additional medicine in order to get your blood pressure to the target that was, your physician or clinician was shooting for. Next slide.
Cynthia, we have a, it's Mary, we have a question.
Okay, could you go back to the prior slide? Could you go back to the prior slide? Okay, yeah, go ahead.
Yeah, about that. So in terms of, selecting the types of harms, beyond side effects and some of those other disease condition outcomes, remedies for the side effect or cost or that burden of treatment, how did you come to those? How did you decide to use those? What were your triggers?
Could you go back to the prior slide, please? Sorry, we were actually going to flip this one that we were on. Yeah, so what we did is after the two topics had been selected in conjunction with people with multiple chronic conditions, and again, their care partners also participated when appropriate, we then recruited additional people for focus groups, so qualitative data collection, where we asked them about outcomes that were important to them. So what outcomes matter to you? And people were selected for those groups on the basis of having, in this case, what we're looking at, high blood pressure and significant additional chronic conditions on the basis of having a QAN score of than 3. And so it was a process that was very much coming from people with multiple chronic conditions in order to generate the list. We did also reflect on the things that were the outcomes measured in the trials for these conditions, but we did also include things for both hypertension and MCCs and diabetes and MCCs. We did also include outcomes that the patients and their families talked about that did not end up being outcomes that were measured by studies. So these lists really came from what people said mattered. The one exception is that people talked about quality of life or function as being important things, and perhaps Milo wants to chime in, but when you're doing best-worst scaling, it's difficult to have an outcome that actually encompasses other outcomes, and so we ended up not including like a generic quality of life kind of measure in the best-worst scaling. But other than that, these are pretty true to what patients and caregivers told us. Milo, I don't know if you want to chime in on that or not.
No, I think fine.
Yeah.
You described it.
If that answers the question, we'll go ahead to two slides. You can skip the next one and go to the one after that.
Yeah, while that's happening, Cynthia, thank you. I think that, was definitely answered the question. But another one came in, too. Can you, just to clarify, is negative the worst?
Yes.
Okay. Thank you.
Oh, yes. Sorry, yes. So we'll go one more after this one. That's just a different way of presenting the data. We decided we want to focus on this one. So one of the things that was really important to us to understand was to what degree there was variability in the preferences for outcomes. And this is a theme we'll be coming back to later as we're looking at the results of the benefit-harm assessment. But what you can see here is basically the median and then the range and then the degree of outliers for each of these outcomes. And a couple of things are key points about it. One is that for many of these things, even within the boxes, there's pretty significant variability in which things would actually be worse than each other. So just as if you're looking at pretty much anywhere, if the ends of the boxes are crossing over into another box, that would mean that there are people who basically rated those two things as in a different order from each other. And so the big take home from this is that there is significant variability in what people's preferences are.
Yes, excuse me, Cynthia, this is Mary. I just want to take the opportunity to ask all participants, when you're not speaking, if you're not speaking, to please mute your line. Thank you.
Oh, sure. And we're not showing the results for this today, but we did. It's a very similar pattern when we look at the same figure with high blood pressure. Those outcomes, it's a very similar pattern. So next slide. So in this slide here, what we are showing is a comparison of guideline developers to people. So we just need to be clear, like up front, that we had a very small number of guideline developers that we were able to interview, and so we view that we were able to survey. So we view this as sort of very exploratory, but one of the things that we have talked about among our group, as well as heard others talk about, is this issue of, do people who are guideline developers, do they weigh outcomes the same as people who are living with the condition? And are there places where what guideline developers think are the most important outcomes and how important they are relative to each other is actually different from the way patients do? And so, you know, just a couple of things to just mention. So we view this as really more exploratory than definitive, but we wanted to share it with all of you, especially for when we get to the discussion at the end, because we do think it's an important point that merits further investigation. But you can see that in general, there were some consistency in how guideline developers and patients rank things, but that there are a number of examples where patients do actually, the lines don't overlap, do actually on average say something is worse or better than guideline developers do. And obviously the red lines for guideline developers are much wider. That's largely just because we had so many fewer in order to assess. We can go on to the next slide. I'll just ask if Milo wants to comment anything on any of the preference results that I presented. I'm turning things back over to him now. So.
No, I think it's fine for the moment. We will come back to it anyway when we include these preferences in the benefit-harm analysis. So we move on now with the actual results. So now we have gathered all our data. We have for many different subgroups. We have outcome risks, we have treatment effect estimates, and we have gotten weights for the outcomes. So next slide, please. Okay, this is just to remember the two questions. We're going to address first the target blood pressure question. By the way, it was a total coincidence that this question was selected almost at the time before the spring trial results came out. So it was, for us, very helpful that the evidence came out, but it was really not selected based on this publication. So next slide. Okay, so here I need to explain again what we do in this benefit-harm assessment. I explained to you that it's basically what we do. We add up the differences in events between two groups, like 140 versus 120 blood pressure, and we weigh the outcomes. What you see here is actually a probability. Why a probability? We do this calculation, so this summing up of the differences, we repeat that many times because we also want to consider the statistical uncertainty around the treatment effects and the outcome risks. So what we basically do behind each outcome risk and treatment effect, we have kind of a distribution that reflects the statistical uncertainty, and we repeat the calculation of this index, again, this summing up of the differences in events. We repeat that summing up, let's say, 100,000 times while drawing from the different distributions from the treatment effects and the outcome risks. So, and from that, we can then calculate what is the probability, for example, that 140 is better than 120. So 0.4 basically means that in 40% of the 100,000 repetitions, 140 was better than 120. And so you see here the probabilities, and we use color coding to indicate what is better. So if it's kind of orange reddish, like graded 0.6, we chose that cutoff arbitrarily. 140 is better. The benefit harm balance favors 140. If it's favoring 120, it's obviously in yellow, so the probability is smaller than 0.4. And what you see here for the general population, so this is the general population with hypertension, so this is a mix of all the patients with few or many comorbidities. We see then in the elderly, the benefit harm balance quite clearly favors the 120 because the probability that 140 is better is very small, whereas it's a little more indeterminate for the age group 50 to 64. Why is that the case? Well, the analyses are, of course, quite heavily driven by the cardiovascular events and death. And the incidence is higher as age advances, and in the trials, there were substantial effects for these outcomes. And since these outcomes are also patient important, like myocardial infarction and stroke, they receive relatively high weights. And this is why the number of benefit events or prevented events is actually greater than the side effects. So let's move to the next slide. This is just overall what we want to show here, and I think this is where it gets interesting, is how the results vary across patients with multiple chronic conditions. And what you see on the left in the first three columns are indicate the subgroups. So if people have diabetes, chronic kidney disease, and heart failure, and on top we have those people who have none of these comorbidities, and at the bottom we have people with diabetes, stage 4 chronic kidney disease, and heart failure. Why did we differentiate between different stages of chronic kidney disease? We realized that the outcome risks, for example, for acute kidney injury, is very different for different severities of chronic kidney disease, and this is why we distinguish between these different stages. When you now look at the colored plot and the different age groups, you see again that in the elderly people, it really didn't matter that much how many comorbidities they had. It was the balance was always favoring the 120 group. Whereas in the 50 to 64-year-old, there's a little more mixed picture because you see that the more severe chronic kidney disease is, the more likely it is that the balance actually favors the 140 group. So you see with this kind of analysis, you can go into subgroups and see whether the benefit-harm balance varies, and this may make you think whether maybe different recommendations should be issued for different subgroups. But let's move on to the next slide, because there is, of course, also the question, how much are the results influenced by how much weight you put on the different outcomes? And this also tells you kind of how sensitive it is to different preferences. On the left, again, the same result as before. So we just weighted the outcomes according to the survey results. In the middle, we showed a picture where all outcomes are weighted the same. You may think this is a little silly to do that, But we do that as kind of a reference point, and also because regulatory agencies like FDA for a very long time stayed away from weighting outcomes, because probably they thought it difficult to assign weights to different outcomes. But this is kind of anchors it when you the analysis or the interpretation when you weigh all the outcomes the same. Why does it now turn mostly to the favor of 140? This is because, of course, there are quite a number of side effects with 120, and if you give more weight to these side effects or equal weight like for stroke and heart attack, the picture changes. But again, if you then move to a situation where you give even more weight to heart attacks and stroke and less weight to some of the side effects, then the picture clearly shows for all age groups that 120 is actually better. What these results show you, we don't want to confuse you with too many results, but this is a kind of the analysis or sensitivity analysis that explore how sensitive the benefit-harm balance is according to preferences. And this may also be something that is important for guideline developers, because if they know that a decision or a benefit-harm balance is preference sensitive, they may issue weaker or whatever recommendation or no recommendation at all, let's say on a population level. So let's move to the next slide. Yeah.
Excuse me, Milo, this is Mary. A question's come in, a clarifying question. So for these, for these probabilities, did you consider time to event? If an outcome is expected to occur after 20 years, it may have a different importance for elderly patients who are more likely to die from another cause before they experience that outcome.
Okay. No, I mean, we didn't. No, we couldn't consider that, because you would basically need individual patient data to have more information on the timing to the events. We just based it on, let's say, published aggregate data. But what it does do, this approach, like say the scale NCI approach, it treats death, all-cause death, as a competing risk. So this is taken into the consideration. But this is a limitation of, like most approaches for benefit-harm assessment are done on the level of aggregated data. We know of treatment, average treatment effects, average outcome risks. And it's very hard to consider, or it requires a lot of assumptions to consider when the different events may occur. There are methods based on individual patient data that address this limitation, but we didn't do that here. Good. Let's move to the next slide. Yeah. So, and next slide is just a repetition that we are moving now to the question on diabetes, on second-line diabetes drugs. So next slide, please. So here again, this is the table that shows you the number of expected events in a particular group of patients, like those with duration of diabetes of 0 to 9 years. And the point that we want to make with that slide is, you know, you just see 6 outcomes that are listed here, and in the preference survey we had like 13, I think. And it just shows you that there's a lack of evidence on quite a few outcomes that matter to patients. And this is just to show you that sometimes when you do this benefit-harm assessment, and anyway, when you also look at meta-analysis, you're just limited by the fact that the evidence doesn't give you the complete picture. And so we can go to the next slide. Here, in terms of results, we don't have to spend too much time here, but we didn't find that much of a difference between metformin and sulfonylureas. So you see the purple color, and then we move one more slide. So this is again on the more population level. Then we go to the subgroups. We see that a small difference between those with duration of diabetes 0 to 9 and those 10 years or more. We see that in the probability that sulfonylurea is better than basal insulin is lower in the age group of 60 to 69. So again, here's a slight indication that the benefit-harm balance varies according to subgroups. But again, these estimates are quite uncertain because we only considered 6 of the 13 outcomes. Next slide, please. Here again, we repeated the analysis according to different weights. Here, the picture again changed for equal weights, but let's say that the two weighting schemes, like the first one, outcomes weighted according to survey, or more important given to some outcomes, shows quite a similar picture. So let's move on to the next slide. So these are our, summing up, these are our suggestions for using the results of such benefit-harm assessments for guideline development. And I will hand over to Cynthia to discuss them and then also to open the discussion.
Yes, thank you, Milo, and I hope that Craig is able to chime in also on this piece. But you know, we've had some preliminary thoughts about using these results for guideline development. So one is to think about how they may affect how we might decide for whom to make recommendations. So for larger groups of patients, for subgroups, or not to make recommendations, depending for the specific questions, depending on how much the benefit-harm balance varies. And that they could be useful for understanding, and I think this was a key take-home for me, of how preference-sensitive a decision is, and to wonder whether they might be useful for understanding whether a recommendation or a decision aid would be more useful. And I think a piece about this just to remember is just to note for these two very common decisions providers are making, how often the outcomes that matter to patients are, we don't have enough available evidence about them, and how that should affect the way we make recommendations. We think it suggests that surveying patients for preferences rather than assuming their preferences are in line with clinician preferences is probably really important, both to understand where they are on average, but also to understand how much they vary. And obviously increasing the available literature about preferences may make that, if there was enough available literature, it may be that you know, could be searched for as opposed to doing it as part of the process of evidence synthesis and benefit-harm assessment. But for these two questions, there were not information available about the outcomes that were identified as important. And then when we make a recommendation, that the estimates of the benefit-harm balance can inform both the wording of it as well as potentially the strength of the recommendation. And I'm thrilled actually that we've got a lot of time for discussion. We can go on to the next, actually we could leave this up for a minute if people want, but I would love to open it up for questions and see if Craig or Milo or Helen want to comment while people are raising their hands or sending questions to Mary.
Hey, Cynthia, this is Craig. Can you guys hear me?
Yeah.
Yes.
Yeah, so I'll just chime in to say that there are a couple of things that, reasons that we really wanted to participate in this from the Kaiser Permanente National Guidelines standpoint. A couple of things have pushed us to acknowledging the importance of trying to get patients kind of more engaged with us. First, you know, the Institute of Medicine report on clinical practice guidelines that you can trust encourages this and sets it as a standard. Since that came out in 2011, we've kind of struggled to figure out how do we put this into play. But having adopted the grade methodology to work on our guidelines, we realize how important it is as well, because as you work from the evidence and try to start writing a recommendation and you think through the strength of recommendation domains, the balance of benefits and harms, the quality of the evidence that you have to work with, patient values and preferences and resource implications, costs, you know, it's very important. Patient values and preferences are called out explicitly, but then the closer you look at the evidence, the more times we find that there really is a balance of benefits and harms to take into consideration. That you know, grade wants you to either recommend things strongly or conditionally, strongly or weakly, and we found that we're writing far more conditional recommendations to offer things in the context of shared decision making than we used to before we started using the grade methodology. So, we've been thrilled to participate in this project, and some of the kind of the suggestions that you see here would certainly align with our experience. I'll let folks know that we've just started sharing this information back to the Kaiser Permanente National Hypertension and Diabetes Guideline teams, and they're considering, whether and how to use this work, but it certainly kind of aligns with where we think we need to go in our guideline development work.
Thanks, Craig. This is Mary. Please send your questions or comments. Please, you don't have to have a question. You could just be making a comment. Please send that along. I'll make sure it gets addressed.
Mary,
yes.
I was just going to say, if you go ahead to 2 slides, we have some discussion questions that may get people thinking about these.
Sure.
Topics. If you go ahead. Yeah.
Sure.
Sorry,
we'll go ahead. Go ahead. And again, I think. Yep, so that was my cue to tell everybody to send their questions, but go one more, because Cynthia wants these questions, right?
Just if we really are, I should state, I don't know if questions are starting to roll in, but we really actually part of a key piece of this is, so this project did not create guideline recommendations, obviously. Like, it was really about methods for benefit-harm assessment and how that can be used to inform decision-making. So a key piece of our project was to gather feedback and thoughts, for the purpose of, continuing to improve methods and move the science along. So we actually are really super interested in your thoughts or questions if people have them. It's actually part of what we wanted to accomplish in the overall project, is to get feedback from as many people as possible.
Great. So feel free to respond to those questions through chat. I can read them out loud to Cynthia and her team. While you're thinking about that, I wanted to ask a question, Cynthia et al. Part of a project that I'm involved in here at AHRQ is really digging down deep and understanding how outcome measures are defined, and perhaps even trying to harmonize outcome measures, so that we can so that we're better able to use the data collected around the measures in research. This project is part of the Registry of Patient Registries work that we do. And so we were prompted to do it when we noticed that different registries actually define an outcome that has the same name very differently. And so when you're looking at outcomes, how did your team come up with not just the outcomes, I think you've addressed that, but more specifically, did you go through an exercise of all agreeing on what did you mean by an outcome? What is that? And convey that then to your participants and others involved in your work.
I'll start off and see if Craig or Milo want to chime in. So it's actually a great question. So for the purpose of doing the benefit harm assessment, we wanted to have information about the incidence of the outcomes from all the places Milo talked about, and then we also wanted to have essentially weights for the the preferences. But an outcome as defined in a trial is sort of like anything above some threshold, but there's obviously a huge range of severity for some of those outcomes, both in the short term and over the long term, like when you think about a stroke, for the impact on the person. But when we were assessing preferences, we wanted to try to anchor people to be weighting the outcomes with some degree of, some common understanding of the degree of severity and the impact on the person. So we actually did spend a fair bit of time working on the definitions of the outcomes for the preference survey. We, as I mentioned earlier, we chose symptomatic versions of those conditions, which is largely relevant for the kidney ones, and we described them in, sort of patient language, and we went through multiple iterations of it. But we did then have to think of, and we tried to choose things of like average severity, where it would have fallen in order to be able to be kind of like matched up with the outcomes that were assessed either in population-based studies or in the trials. But so it's definitely an area though that I would say we learned a lot, and I think there's a lot of work to be done in terms of thinking about how we end up incorporating patient preferences in this type of work. I don't know if Milo or Craig want to chime in anything.
Yeah, this is Milo. Maybe a brief comment. I mean, we had control over the preference data because it was up to us and together with the caregivers and patients to define those outcomes and make them understandable. So that was good. So we hope we knew what we were talking about. When it comes to outcome risks and treatment effects, you have to deal with what is out there in the literature and try to understand how they define outcome, which is not always easy. And what we really try to do is to pick those pieces of evidence where we, let's say, understood the outcomes, or if it was based on a meta-analysis, where we're confident that the outcomes were measured more or less in a similar way. But yeah, if you deal with published data, and of course you should take advantage of that, but you don't have that much control over the how outcomes are defined. And I would welcome it very much if this was done more consistent. And in some fields, I think in the rheumatology with the OMERACT exercise, it is much more consistent how outcomes are defined than in other areas.
Thank you. I have some other questions I'd like to ask from the audience. Could you, let's see, there's a question about will your results be published or made public? And I think you have been already publishing, as you had indicated, right, Cynthia? So maybe you could address that again.
Sure. So we have one paper that was published in JGIM that was about the process of choosing the questions, and we have several other papers that are in basically either already submitted or under in close to being submitted. So absolutely planning on publishing them as soon as we can.
Thank you. A question about getting the patient input. I believe you had noted that you used some focus groups. Were they were in-person, virtual kind of groups? And what are your thoughts about even expanding that to doing some kind of crowdsourcing?
That's a great question. So yes, they were in person, and for budgetary and logistic reasons, they were all people who lived in and around the Denver area who were members of KP Colorado. We were really, I think there was real value in sort of the for this patient population that we were interested in making sure we had the older perspective and the perspective of people who were relatively ill and in terms of their degree of multimorbidity. And so, but I could envision if you were studying a population that was I'm not positive for older people with multiple chronic conditions, like a crowdsourcing kind of online thing would have captured the perspective of the people we were going after, but I definitely think in general that's a really interesting and innovative way that deserves more thought. I'll let Craig, if he wants, chime in on any thoughts. He attended all of the focus groups. I attended some of them.
Yeah, I think that gets kind of the contrast of what you might get out of crowdsourcing versus what you might get out of a smaller focus group gets a little kind of quantitative versus qualitative information, right? So we were hoping by having the focus groups that we would really get rich information from them, but it's going to be more qualitative type research. And then if we were to do something, you know, where we opened it up and had kind of a crowdsourcing opportunity for people, then what you'd be hoping is that by capturing more data, you're going to get better data. So, so anyway, it's very interesting. We didn't really, you know, think about doing it that way, but it's something worth considering.
Yeah, this is Mary. I mean, there's a whole movement around citizen science, right? So I appreciated that question too. There was a question about, you know, the subgroups, and you've explained, I think, in your last response, Cynthia and Craig, about your focus groups were, you know, basically out of Kaiser, Colorado. So, you know, certain population type there. What about some subgroups? Were you able to do any analyses, even if it was smaller, around some different minority groups? And did they show differences?
I'll speak to that a little bit. So we had about 200 people in each group, and the population of respondents was pretty similar to non-respondents in terms of gender, race, and ethnicity. We had slightly less, but you know, the numbers are not huge, so it's hard to know if it's like meaningfully less people who are Hispanic, perhaps because of the language issues participating. I don't believe that we have enough numbers of any particular ethnicity or minority group in order to be looking at our preference data for that. I'll just mention that we were really interested in whether we could see how much variability there was in preferences, but our primary hypothesis going into that was around age and degree of multiple chronic conditions. We ended up finding that there was significant variability but in the preferences, but that it wasn't predictive, able to be predicted by, like, you know, the presence of a specific condition or the severity of multiple chronic conditions. I will note, though, that everyone we included had very significant multiple chronic conditions, and so there might have been a difference across degree of multiple chronic conditions had we included people who had diabetes and nothing else, or hypertension and nothing else. And by nothing else, I mean no other major chronic condition. So we really can't say that preferences don't vary across the degree of multiple chronic conditions, because everyone we had a very significant degree of multiple chronic conditions. I don't know if there's more questions that you want to get to, but we could ask Milo or Helen to chime in about that further if they, if there's time.
Okay. Yeah, I do have another question to ask.
Okay.
You know, some guideline groups are under-resourced. Others are under tremendous pressure to have recommendations done yesterday. You know, can you suggest what groups like that might do to operationalize methods that you've described today so that they can be done faster and more efficiently?
Yeah, that's really a great question, and it's one that we have reflected on. I do think that, you know, if we were to do this again, I think we would be able to be faster at every step, but I still do think that it would be, you know, not necessarily in the kind of rapid, the really rapid getting to guideline development recommendations piece. I will just add, and then I'm sorry, Craig, I hope you're not feeling put on the spot, let you chime in about it, that I do think if there was more data available about preferences across diverse populations in terms of race and ethnicity, but also degree of multimorbidity, and that we were really assessing that in the literature that would potentially be able to be captured and utilized and by all guideline groups. Like our preference data is going to be available to anyone. Craig, do you have thoughts on how to address that question? It's really a great one.
Yes, I don't know that I have a kind of the wonder answer or the absolute right thing to do, but we took this question to our integrated cardiovascular health leads in the hypertension and diabetes group guideline development teams. They were interested in the concept, but did start to ask kind of the feasibility of doing it in our guideline program right off the bat. And so I mean, I think it's one of these things where the, guideline workers would like to be able to have other reputable groups, other people who do high quality work around the evidence, do the hardcore evidence work, I think, and then hand it off for us to work through kind of the process of the recommendation writing. So, for instance, in our national guideline program work, we've realized one of the ways for us to be most efficient at Kaiser Permanente is if somebody else has done the legwork on the evidence and we can get an efficient quality of evidence grade, that our sweet spot is then working with that evidence in our own guideline development teams to go through the grade strength of recommendation domains and decide on recommendations for our healthcare system. So if if there were research groups, systematic review groups that really took this benefits harms analysis and ran with it and could have that produced for us, I think it would be more useful to us in a guidelines shop that's trying to get as efficient as we can, writing recommendations.
Mm-hmm. Thank you. A comment has come in, not a question, so maybe you could respond to this comment. Polling stakeholders first about what they think is the most critical outcomes to be considered by the guideline panel, and then taking that data and asking patients to reflect on it and add what they see as the critical outcomes. Converging and diverging on opinions could be perhaps another way to approach it. What do you think about that? And and perhaps that's another way too to get at some of those other contexts that are also important, those other types of outcomes like cost and resource use.
That's a great question. So I think we did do that to some degree. So we when we went to our patients and caregivers, we did go starting off very open-ended, wanting to hear what outcomes mattered, but we did also ask them about the outcomes that were sort of already kind of on the list that guideline developers, if that's what you meant by stakeholders, would already have been considering. But, I think that sort of idea of making sure we're getting both perspectives is really important. Like, we didn't want to leave out an outcome. We did leave out things that were not patient-important outcomes. So, like in our diabetes assessment, we did not have hemoglobin A1C as an outcome. So we did focus down on things that sort of met the threshold of being a patient-important outcome, but we did try to have that convergence of the perspectives of what we measure in trials and what matters to patients. Anyone else want to chime in? Mary, do you think that addressed the comment?
Yeah, I sure do. Thank you for responding to that comment. I want to extend, if you don't mind, prior question. Do you view these methods as critical to guideline development, and that would, help make the guidelines more implementable, or is it just nice to have? How key is this? Is the evidence about, the methods that you talked about today sufficient to push them into operationalizing them in guideline panels? Could you talk about that, the readiness and the value, more about that?
So I'll just note that I think figuring out how to inform decision-making in a way that recognizes people have multiple chronic conditions and may have variable preferences, probably really biased, but I think that's super important.
Sure.
I'll let Craig and Milo maybe chime in for the broader part of your question.
Yeah, this is Milo. I'm happy to. You know, I think it's, of course, I'm also biased, but I think it's really important because we have some examples where guideline developers, different guideline developers, based on exactly the same body of evidence, come to completely different conclusions. So the low-dose aspirin for primary cardiovascular prevention is an example, and I think that the reason is that these guideline developers just didn't go through like a systematic assessment of the benefits and harms, and it was not transparent or not clear at all how they arrived at the conclusion. The United States Preventive Services Task Force is probably the only one that did a little bit of that. So I think these methods are important because you can also discuss the assumptions you made and everything you made, everything explicit how you arrive at the recommendations. And I think if these methods are not used, you may come up with very discrepant guideline recommendations. And most importantly, it's just not transparent and not clear why guideline developers may arrive at a certain recommendation.
And this is Craig. I would. Mary, I would just jump in to add that the question of whether it's nice to have or important, I think all of us would say it's important. The reason it becomes nice to have for a lot of groups is a resource constraint. And so that just, you know, it would harken back to a comment I made before, that if we could get people who are skilled in this doing it and putting it in the public domain so that guideline developers and writers have it available, I think a lot of us would agree that it would make our work better. You know, when we first switched to grade at KP, you know, I think a lot of our analysis of patient values and preferences and how that should play into a recommendation that we might write was really just getting the gestalt of the guideline development team members, right? Just sort of what do you think with your patients or with you personally or with your family, and it was sort of a stand-in for it. So I think there's discomfort with that, but the reason that I think one of the main reasons is that it's hard to get beyond it is just, you know, resource limitations and time constraints and the press of, you know, getting things done. So, you know, just like the recent Global Evidence Summit, when we're trying to think across the whole evidence creation, synthesis, and implementation spectrum, if we could get different groups, you know, with skill sets producing things in efficient ways that the next group in line could use it effectively, that would be great.
Thank you, Craig. Cynthia, Milo, Helen, Craig, you have lit up a firestorm because we've gotten, you know, more comments and questions than I can ask of you. We're getting down to the end of our time. So,
okay,
Cynthia,
Mary,
trying to say something?
Oh, I was just going to remind people we wanted to go on to the one last slide, but you can do that after.
Yeah, absolutely. So I just wanted you to know that before we wrap this up, that in fact there were some additional questions. And I wanted folks to know to look at your chat because Ilka from Finland, Dr. Kanama has sent a chat to everyone talking about work they're doing in Finland. So feel free to look at that while we go to the next slide.
Oh, yeah, sorry, Mary, I didn't mean to cut you off. I just, I'm thrilled to hear people are interested and have more questions and comments for us. After the survey, Mary is going to send out after the webinar, Mary is going to send out a very brief survey where you can tell us anything and everything you think we should be thinking about, feedback, further questions. We'd be happy to be contacted. We are super interested in all of your thoughts and questions, and when we are writing up sort of the reflection on the methods, if you wish to be acknowledged, we would be for giving us feedback, we would be happy to do so. And in the survey that will come, there will be a place where you can tell us your name and where you are. You're also welcome to fill out the survey anonymously, though, and we really appreciate all of your interest and your thoughts. So, and thank you to GIN North America for inviting us to do this. And on our very last slide here, we just wanted to include our full team. And Mary, back to you.
Thank you, Cynthia. And we put that slide back so that we could give proper attribution to the team. Big project, lots of exciting things that you're doing. I know when Craig called me to say, hey, we're doing this, you think we could have a spot in your, in your lineup. I was very excited about what you've done. I think the preference solicitation survey work, especially to the guideline community, is right on. So thank you for reaching out and for following through. Do appreciate it. So with that, I want to, thanking the speakers and their teams, and thanking each of you, the participants, for bearing with us as we rescheduled this. Sorry about that, right? It's life, it happens, and we have to do it. But thank you for bearing with us, and feel free to let your colleagues know about the recording. We will announce it when it's been posted. In the meantime, if you liked this kind of webinar, please send your comments and suggestions for others for research in progress to guidelines.northamerica@gmail.com. And we will get it. So with that, thank you, everyone.
Thanks, Mary.
Thank you. Thank you.
Bye-bye. Thank you. Good job.